welcome to the deep dive. Today we're jumping into pediatric nursing care, specifically the genitourinary and renal systems.
Yeah, that's right.
And it's crucial to understand right off the bat, treating kids isn't just scaling down adult care, especially here.
Oh, definitely not. The differences are significant.
Yeah, and the stakes are incredibly high. Get this wrong, and you could be looking at chronic renal failure down the line, or even impacts on future reproductive health.
Absolutely. So our goal today is really to distill the essentials straight from our nursing source material. We want to quickly cover why kids' GU systems are so vulnerable, nail down the key assessment points, and highlight the critical nursing actions for common conditions.
Think of it as a clinical shortcut for these complex patients.
Exactly. Clinical readiness is key.
Okay, so let's dive right in. Why are children, especially the little ones, infants and toddlers, so much more vulnerable when it comes to GU issues?
Well, it boils down to two main things: anatomy and functional maturity, or rather immaturity.
Anatomy first, then. What are the key differences?
Okay, so picture the kidneys. In a child, they are proportionally much larger compared to the size of their abdomen than in an adult.
Bigger targets, basically.
Sort of, yeah. But more importantly, they don't have the same protection. Less fat padding, and the rib cage doesn't cover them as effectively.
So any bump or fall, especially to the flank area, puts those kidneys at a much higher risk of injury.
Precisely. That lack of natural cushioning is a major factor.
And what about infection risk? You hear a lot about UTIs in kids.
Right, that comes down to the urethra. In females, it's shorter across the board, but in infant girls, it's also really close to the rectum, which increases the risk of E. coli contamination.
Makes sense. What about boys?
Well, adult men have that long urethra offering protection, but young boys don't. Their urethra is significantly shorter than an adult male's, so they're actually more prone to UTIs than you might initially think, certainly more than older males.
Okay, so anatomy makes them vulnerable to trauma and infection. What about the functional side, the immaturity you mentioned?
Yeah, this is critical. The glomerular filtration rate, or GFR, is just naturally slower in infants and young toddlers. Their kidneys aren't fully developed yet.
And what does that mean clinically? Slower filtration means?
It means they're less able to concentrate urine effectively. They also don't reabsorb amino acids as efficiently.
So put that together. If they get sick, maybe vomiting or diarrhea.
Exactly. They are at an incredibly high risk for dehydration, and it can happen fast. That renal system doesn't really hit full functional maturity, adult level concentration ability until they're about 2 years old.
Wow, 2 years. And you're dealing with tiny volumes too, right?
Oh, absolutely tiny. A newborn's bladder might only hold 30 millimol. Even by age 1, it's maybe up to 270 millimils. So that expected urine output, that vital sign we watch like hawks, is a really narrow range, 0.5 to 2 millimils per kilo per hour.
Okay, that paints a clear picture of the vulnerability. So shifting to the nursing process, how does this impact our assessment? History taking must be different.
Completely different. You can't just ask about burning when they pee. You need to dig deeper. Think about maternal history. Was there polyhydramnios? Maternal diabetes? These can be flags for congenital renal problems.
What about family history?
Crucial. Ask about bedwetting, enuresis, or kidney stones in parents or siblings. That suggests a potential genetic link.
And for the child themselves, beyond the obvious GU symptoms.
Look for systemic clues. Is there poor growth? That can be a sign of chronic kidney issues. Any generalized swelling, edema, or recent infections, particularly strep A, that points towards things like post-strep glomerulonephritis.
Got it. And the physical exam, what are the pediatric specifics there?
Inspection is key. Look for pallor that could signal anemia tied to renal disease. And edema often starts around the eyes, that periorbital puffiness. If it's severe and all over, that's anasarca. Also check the urethral opening for abnormal placement.
And listening, auscultation.
Check heart sounds. Sometimes you'll hear a flow murmur if there's anemia. And here's a practical tip. For blood pressure in little ones, you must use the bell of the stethoscope. Those Karakoff sounds are much softer, and the bell picks them up better.
Good tip. What about palpation, feeling the abdomen?
Well, normally you can't really palpate the kidneys easily in older kids or adults. So if you can feel a kidney in a child, that's a big warning sign. It could mean enlargement or even a mass like a tumor.
Okay. And you also check for CVA tenderness, costovertebral angle tenderness, for kidney infection, and maybe percuss for bladder fullness.
Exactly. Dullness above the symphysis pubis tells you the bladder's full.
Let's talk diagnostics. Labs are huge in renal care. What are the key ones nurses track?
VUN and creatinine are staples, of course, but serum creatinine is really our benchmark for GFR. Here's a key relationship to remember. If the serum creatinine doubles, it generally means the GFR has dropped by about 50%.
Wow, that's a direct correlation.
It gives us a really good, quick snapshot of kidney function decline.
And for a more precise GFR measure.
That's the creatinine clearance test. But it's challenging in pediatrics because it requires a timed, usually 24-hour urine collection.
Right, getting all the urine from a toddler for 24 hours.
Exactly. You have to be meticulous, instruct the family, discard the very first void, then collect everything for the next 24 hours. And keep it chilled, usually on ice the whole time. Accuracy depends on it.
And electrolytes. Potassium is always a concern with kidneys.
Always. Hyperkalemia is a major risk, especially in acute kidney injury. If you see a critically high potassium level on the labs, that's an immediate notification to the provider. It's a cardiac emergency.
Okay. What about imaging or procedures?
Avoiding cystoarthrogram, or VCUG, is common. It involves catheterization, which isn't fun for the child, but it's essential for diagnosing vesicular reflux, that backflow of urine, or other structural problems.
And if they need a renal biopsy?
Post-procedure care is critical. The child needs to lie flat, completely supine for 24 hours.
24 hours flat for a kid. That sounds difficult.
It is. The biggest nursing challenge there is managing pain effectively and providing lots of distraction to ensure they stay put and minimize bleeding risk. You monitor constantly for any flank pain or rising heart rate, signs of internal bleeding.
Before we leave assessment, how do we get that urine sample from an infant or toddler who isn't potty trained?
Good question. For a sterile sample, sometimes suprapubic aspiration is done by the provider, but for routine urinalysis, the urine bag is common.
Right, the little sticky bag.
Yeah. You clean the perineal area well, maybe use a little benzoin to help the adhesive stick, apply the bag carefully, and tuck it down inside the diaper. And remember, catheter sizes are tiny, like a 6 French for babies up to age 2.
Okay, let's move into specific conditions, starting with structural disorders. These are often congenital, right?
Often, yes. Bladder exstrophy is a really dramatic example. The bladder is literally open and exposed on the outside of the abdominal wall. Often the pelvic bones are malformed too.
That sounds incredibly challenging to manage preoperatively.
It is. The priorities are protecting that exposed bladder tissue and preventing infection. The infant has to stay supine. You cover the bladder with a sterile plastic bag or moist sterile dressing to keep it from drying out.
And hygiene.
Sponge baths only. No immersion, obviously. Post-op, managing bladder spasms is huge. Medications like oxybutynin or sometimes a belladonna and opium B&O suppository are used. And here's a really important safety alert for all kids with congenital urologic issues. They have a super high risk for developing a latex allergy.
Why is that?
Repeated exposure during surgeries, catheterizations, procedures, it sensitizes them. So you must use latex-free everything for these kids. Gloves, catheters, tape, everything.
Good point. What about misplaced urethral openings, hypospadias and epispadias?
Right. Hypospadias is when the opening is on the ventral side, the underside of the penis. Epispadias is dorsal on the top side. It can occur in females too, but it's more common with bladder exstrophy.
And the goal of surgical repair?
Usually done between 6 and 12 months. The aim is to create a cosmetically normal penis, allow the boy to avoid standing up, and ensure normal sexual function later in life.
What's key post-op?
Managing the urethral stent or drainage tube is primary, and teaching parents that double diapering technique.
Oh yeah, tell us about that.
It's quite clever. You put on a smaller diaper first, cutting a hole for the penis and stent. This diaper collects the stool. Then you put a larger diaper over that, which collects the urine draining from the stent.
Ah, so it physically separates the bowel movement from the urinary output and the surgical site. Brilliant. Prevents contamination.
Exactly. It's a great way to protect the repair. Also, important to restrict activities where they might straddle things like riding toys for about 4 weeks post-op to avoid injuring the site.
Okay, what about obstructions? Blockages in the urinary tract.
Obstructive uropathy can happen at different points where the ureter meets the kidney pelvis, UPJ, where it meets the bladder, UVJ, or sometimes from posterior urethral valves, which only occurs in males.
Then the consequence is?
The hydronephrosis. The backup of urine causes the kidney pelvis to swell. If surgery is done to fix the obstruction, there's a critical fluid management point.
Which is?
You absolutely must withhold potassium from any IV fluids until you're sure the child has established good urine output. If the kidneys aren't working well post-op, giving potassium could quickly lead to dangerous hyperkalemia.
Got it. Hold the K+ until they pee. Now, what about Visicoretal reflux, VUR.
That's the backward flow of urine from the bladder up into the ureters, sometimes all the way to the kidneys, especially during voiding.
And the risk there.
Kidney infections, pyelonephritis. Repeated infections can cause scarring, which can lead to high blood pressure later in life.
How does it manage?
Lower grades, I and II, often resolve on their own as the child grows. But higher grades, 3rd of E, usually need surgical correction, reimplanting the ureters into the bladder at a better angle. Sometimes prophylactic antibiotics are used while waiting for a resolution or surgery.
Okay, shifting from structural to more common acquired issues. Let's talk UTIs. Super common, right?
Yeah. Incredibly common in pediatrics. We already mentioned the shorter female urethra and proximity to the rectum. Other risk factors include poor hygiene, especially in preschool girls learning to wipe, constipation, which can press on the bladder, being uncircumcised for males, and sexual activity in teens.
And the culprit is usually?
Overwhelmingly E. coli. The key issues promoting growth are urinary stasis urine sitting in the bladder too long and alkaline urine. Bacteria love that environment.
What makes UTIs tricky to diagnose sometimes?
The symptoms can be really vague, especially in infants. They might just have a fever, be irritable, feed poorly, maybe have jaundice. It's not specific. Older kids might finally show classic signs like dysuria, painful urination, urgency, frequency, or even new onset bedwetting or daytime accidents.
So prevention is key. What do we teach parents?
Lots of fluids. Some evidence suggests cranberry juice might help slightly by acidifying urine, though it's not definitive. Avoid bladder irritants like caffeine and carbonated drinks. Encourage frequent voiding, don't hold it. Proper wiping technique, front to back for girls. And breathable cotton underwear.
That leads nicely into enuresis, or incontinence past the age of expected dryness.
Right. We need to differentiate. Is it primary, meaning the child was never consistently dry, or secondary, where they were dry for at least 3-6 months and then started having accidents again? And is it diurnal, daytime, nocturnal, nighttime, or both?
What causes it, besides just habit?
Sometimes it's simple things like drinking too much fluid before bed. Constipation is a big factor. The full rectum presses on the bladder. Sometimes it's dysfunctional voiding patterns, and there's often a strong family history.
How is it managed? Is medication the answer?
Evidence really points to behavioral therapy as the mainstay. Things like enuresis alarms, which wake the child at the first sign of wetness, can be very effective over time. Limiting fluids after dinner helps. Medications like desmopressin, DDAVP, can work temporarily, but there's a high relapse rate when you stop them. The key is positive reinforcement, no punishment, and patience.
Okay, let's tackle some of the more serious acquired conditions. Minimal change nephrotic syndrome, MCNS. What's happening there?
The core problem in MCNS is a sudden, massive increase in the permeability of the glomeruli in the kidneys. They start leaking huge amounts of protein, almost excluding
Proteinuria, what does that lead to?
Losing all that albumin from the blood causes hypoalbuminemia. This drops the plasma oncotic pressure, so fluid shifts out of the blood vessels and into the interstitial tissues. That's where the massive edema comes from, starting periorbitally, then becoming generalized anasarca.
And the body tries to compensate.
Yeah, the liver tries to make more albumin, but it also ramps up production of lipoproteins, leading to hyperlipidemia. These kids are also strangely susceptible to infections, especially pneumococcal pneumonia and peritonitis, and they have an increased risk of blood clots, thromboembolism.
How do we manage that massive fluid shift?
Promoting diuresis is key. Daily weights are absolutely the best indicator of fluid status changes. We restrict fluids and sodium. In severe cases, we give IV albumin to temporarily pull fluid back into the vascular space.
And then hit them with a diuretic right after.
Exactly. You give the albumin infusion and then immediately follow it with a diuretic like furosemide to help the kidneys excrete that excess fluid quickly before it shifts back out. It maximizes the effect.
What's the main treatment for MCNS itself?
Corticosteroids, often long-term courses. And this brings significant psychosocial challenges.
Ah, the side effects. Moon face, weight gain.
Right. Mood swings, increased appetite, potential for slowed growth. It really impacts body image, especially for adolescents. We need to support them and their families through that. And crucially, steroids must be tapered slowly when discontinued to prevent acute adrenal insufficiency. Never stop them abruptly.
Okay. Two other big causes of acute renal failure, APSGN and HUS. Let's start with APSGN.
Acute post-streptococcal glomerulonephritis. This is an immune response that happens usually 1–2 weeks after a group A strep infection, like strep throat or impetigo. The immune complexes damage the glomeruli.
What are the hallmark signs?
Think of the triad. Hematuria of the urine often looks tea-colored or cola-colored. Edema, again, often starting periorbitally.
Right.
And hypertension.
And the other one, HUS.
Hemolytic uremic syndrome. This also has a classic triad. Hemolytic anemia, red blood cells breaking down. Thrombocytopenia, low platelets, and acute renal failure.
What usually causes HUS?
The most common culprit is infection with the specific strain of E. coli, O157.H7, which produces a nasty toxin called verotoxin or Shiga toxin, often linked to contaminated food, especially undercooked ground beef or unpasteurized juices or contaminated produce.
So prevention is huge here. Cook meat thoroughly.
Yes, ground meat should reach 155 degrees Fahrenheit internal temperature. Wash fruits and vegetables well. Hand washing is critical. And if a child does get HUS, they need contact precautions because they can shed the bacteria in their stool for a long time, up to 17 days, even after diarrhea stops.
How do we manage acute renal failure in general from either cause?
It's mainly supportive. Treat the underlying cause if possible. Manage fluids and electrolytes very carefully. Hyperkalemia is a big risk, so we might use medications like sodium polystyrene sulfonate, kayexalate, to lower potassium. Monitor intake and output religiously. And a key point, avoid nephrotoxic drugs like NSAIDs or certain antibiotics like aminoglycosides.
If the kidneys fail completely, leading to end-stage renal disease, ESRD, what's different about ESRD in kids compared to adults?
The primary cause is usually different. In adults, it's most often diabetes and hypertension. In children, ESRD is most commonly the end result of congenital structural defects like the ones we discussed earlier, or reflux nephropathy.
And the complications for kids with ESRD are devastating, I imagine.
They really are. Severe anemia, difficult to control hypertension, growth failure, bone problems called renal rickets, plus the immense psychosocial burden. Depression, low self-esteem, frequent hospitalizations, missing school. It's incredibly tough.
What are the options when dialysis is needed?
Two main types: peritoneal dialysis, or PD, and hemodialysis, or HD.
PD is usually done at home.
Right, often overnight while the child sleeps using a cycler machine. It uses the peritoneal membrane in the abdomen as the filter. The big advantage is more freedom, a more liberal diet usually, but the major risk is peritonitis infection in the abdomen. Strict, sterile technique during connections and disconnections is absolutely essential.
What's the key sign of peritonitis nurses look for?
Cloudy effluent. The dialysate fluid drained out should be clear. If it looks cloudy or has flecks in it, that strongly suggests infection, needs immediate attention.
And hemodialysis?
HD is usually done in a dialysis center, maybe 3 or 4 times a week for several hours. It requires vascular access, usually an arteriovenous AV fistula or graft, typically in the arm.
And there's a critical nursing alert for that access site, isn't there?
Absolutely non-negotiable. You never take a blood pressure, start an IV, draw blood, or even place a tourniquet on the arm that has the fistula or graft, ever. Protecting that access is paramount. Occlusion means they can't get dialysis.
Wow. So the best long-term solution is often transplantation.
Renal transplantation offers the best chance for a more normal life, yes. But it comes with its own challenges. Primarily the lifelong need for immunosuppressant medications to prevent rejection.
And adherence to those meds is critical.
Absolutely critical. Missing doses can trigger rejection. Nurses play a huge role in education and reinforcing that regimen. These kids should also wear a medical alert bracelet and avoid live virus vaccines because of the immunosuppression.
We've touched on it throughout, but let's explicitly address the psychosocial side. The impact must be enormous.
It's pervasive. Think about the chronic stress, frequent clinic visits, hospital stays, dietary restrictions, the visible signs like edema or the dialysis access site, side effects from meds like steroids. It impacts school, friendships, body image, everything.
How can nurses help?
Encourage peer support groups. Connecting with other kids going through similar experiences can be incredibly helpful. For adolescents, involve them in treatment decisions as much as possible to give them a sense of control. Provide resources for mental health support for the child and the whole family.
Before we wrap up, we should briefly touch on some reproductive system disorders mentioned in the source. For females,
A few common things. Labial adhesions, where the labia minora fuse together, are usually treated simply with topical estrogen cream. Pelvic inflammatory disease, PID, is a serious infection of the upper reproductive organs, often caused by STIs like chlamydia or gonorrhea. It's a major risk factor for chronic pelvic pain and infertility later on.
So a key nursing role there is.
Confidential conversations about sexual health, risk factors, and consistent education about safe sex practices, especially condom use for adolescents. Also, managing menstrual disorders like dysmenorrhea, painful periods. NSAIDs work well because they inhibit prostaglandins, which cause the cramps.
And for males, what are the key things to know?
Phimosis is the inability to retract the foreskin. Paraphimosis is when the foreskin is retracted but gets stuck and can't be pulled back down. Paraphimosis is a medical emergency because it can cut off blood flow.
Okay, that's urgent. What else?
Testicular torsion, a sudden twisting of the spermatic cord, causes abrupt, severe scrotal pain. This is also a surgical emergency. Time is testicle, they say. Any delay risks losing the testicle.
And undescended testicles. Cryptorchidism.
Right. If one or both testicles haven't descended into the scrotum by about 6 months, intervention is needed. Surgical repair, orchiopexy, is usually done by 12 months of age. Waiting longer increases the risk of infertility and testicular cancer later.
One last practical point. Circumcision care. Key instructions for parents.
Pain management is important, using acetaminophen as ordered. Keep the area clean. Apply petroleum jelly to the site with each diaper change for several days to prevent sticking. And crucially, instruct parents to watch for the first void the baby should pee within 6 to 8 hours after the procedure. If not, they need to call.
Okay, that was a comprehensive run-through. Let's try to distill the absolute key takeaways. If someone remembers only 3 things from this deep dive, what should they be?
All right, 3 nuggets. First, pediatric GU is defined by immaturity and vulnerability. Think slower GFR, shorter urethra, less protection. That dictates risk.
Makes sense. Number 2.
Second, chronic management hinges on vigilant monitoring. Daily weight is your absolute best friend for tracking fluid status. And electrolytes, especially potassium, need constant attention.
Okay, immaturity, vulnerability, and monitoring. And third,
Long-term success depends heavily on adherence and support. Adherence to sterile technique in PD, adherence to meds post-transplant, and providing strong psychosocial support to navigate the challenges of chronic illness.
excellent summary. So to leave our listeners with something to think about, building on that last point about adherence and psychosocial needs.
Yeah, here's a tough question we grapple with in practice. How do you, as the nurse, balance the strict medical necessity of long-term adherence, taking those crucial immunosuppressants every day, following fluid restrictions meticulously with the totally normal developmental drive of an adolescent pushing for independence, for control over their own body, especially when the treatments themselves, like steroids causing that moon face, directly impact how they look and feel about themselves?
That's a really powerful question. It highlights the art, not just the science, of pediatric nursing in chronic conditions. A vital challenge indeed.
It really is.
Well, thank you for joining us for this deep dive into the essentials of pediatric GU and renal nursing. We hope this helps clarify these critical concepts.
Yes. Thank you for tuning in. Stay curious, stay well, and we'll catch you on the next deep dive.